Hello, everybody. This is Biykem Bozkurt. I'm thrilled to present on the current guidelines and management strategies in patients with heart failure. These are my disclosures. In the 2022 US guidelines, we have specified initiation of quadruple therapy, specifically with RAS inhibition with ARNI in NYHA class 2 and 3, ACE inhibitors, ARBs in NYHA class 2 to 4 heart failure patients, and beta blockers, mineralocorticoid receptor antagonists, and sodium glucose cotransporter 2 inhibitors. These 4 classes of medications as the first foundational step in treatment of patients with heart failure with reduced EF. In the 2023 ESC guidelines, the treatment of heart failure with reduced EF has a very similar recommendation of initiation of quadruple therapy in all patients with symptomatic heart failure with reduced EF. In the ESC guidelines, ARNI initiation is recommended, however, to be initiated after patients have been on ACE inhibitors as a switch among those who have been able to tolerate ACE inhibitors as a class 1 indication. In the US guidelines, we didn't require the patients to have to be on ACE inhibitors prior to initiation of ARNI and have a class 1 recommendation for initiation of ARNI as a de novo treatment in patients with heart failure with reduced EF. Specific feature of which patients are not recommended to be initiated on ARNI are NYHA class 4 heart failure patients. These patients were not represented in large scale in the large-scale clinical trials that were conducted with ARNI, and therefore we did specify ARNI is indicated in NYHA class 2 to 3 heart failure patients. The evidence to support this recommendation is quite strong. As seen on this slide, we have large-scale trials with ARNI from the PARADIGM trial and with SGLT2 inhibitors with dapagliflozin and empagliflozin from large-scale trials demonstrating benefit in cardiovascular death and heart failure hospitalization within a few weeks after initiation, as seen on this slide. The second step in the US guidelines is optimization of the doses, the up-titration of the doses. This was predominantly important for beta blockers and ACE inhibitors, but we also recognize that there is evidence of reversal of remodeling with ARNI, as well as SGLT2 inhibition, at least by what we see in ejection fraction and LV volumes. Thus, before consideration of ICD and CRTD, it is very important for us to optimize the GDMT with quadruple therapy with optimal doses. There is evidence that intermediate doses with ARNI could be as good as the maximum doses, but at least there should be an attempt for up-titration of the doses. In ACE inhibitors and beta blockers, we recommend the maximum tolerated doses. SGLT2 inhibitors are only 1 dose, and MRA is only 1 to 2 doses. The next step is important. With class 1 recommendation for initiation of hydralazine nitrates in African American or Black patients. This is a class 1 recommendation in the US guidelines, but in the 2023 ESC European guidelines, initiation of hydralazine nitrates is given a class 2 recommendation. That's an area that we differ from the European guidelines. The initiation of additional therapies, which I will present in the next few slides, is very much harmonized. But as the next step after the quadruple therapy, optimization of doses, addition of hydralazine nitrates in Black patients, we do recommend consideration of ICD-CRTD. This is important after you optimize the doses and we check the ejection fraction to make sure that the patient still qualifies for the device indications. The device recommendations have not changed for ICD and or CRTD in the last guidelines. At this next phase, we also recommend further optimization of heart failure therapy because heart failure is a deadly disease. When patients have active symptoms, it is critical for us to continue further optimization of therapies. Ivabradine is recommended as a Class 2A recommendation in both US and ESC guidelines among patients with heart rate exceeding that of 70 beats per minute in sinus rhythm on optimal doses of beta blockade. Vericiguat, digoxin are given a Class 2B recommendation in both US as well as ESC guidelines. We did specify that potassium binders could be considered among individuals with hyperkalemia in the setting of RAS inhibition in the US guidelines as a Class 2B. Consideration for transcatheter edge-to-edge mitral valve repair has a Class 2A recommendation among patients with severe secondary functional MR with the optimal anatomy as represented on this slide, only after optimization of guideline-directed medical therapy, which has a Class 1 recommendation. In the US guidelines, we approach the initiation and optimization in a stepwise manner. As you could see, we have, as I have formulated, we have step 1, initiation of quadruple therapy. Step 2, optimization of doses. Step 3, look at the patient's trajectory, reassess, add dihydroxyzine nitrate in Black patients, ICD-CRT, and additional therapies. And of course, in very advanced heart failure patients, we must consider appropriate referral to tertiary quaternary referral centers, consider advanced therapies such as ventricular assist devices, cardiac transplantation, and other supportive care. Transitioning now to patients with mildly reduced EF as well as preserved EF. As seen on this slide, we have strong evidence from 2 large-scale trials among patients with heart failure with EF exceeding that of 40%, that there is benefit in reduction of cardiovascular death and heart failure hospitalizations with SGLT2 inhibitors. And this benefit is seen as early as 18 days after initiation of SGLT2 inhibitors. One of these trials, the DELIVER heart failure trial, was conducted after we published, after the US guidelines were published. On the left side, I listed the US guidelines after one trial, where we listed for patients with mildly reduced EF, SGLT2 inhibitors were given a Class 2A recommendation because we only had one trial at that time in 2022. And the other agents, all other agents, including ACE inhibitors, ARNI, ARBs, MRA, and beta blockers were given a Class 2B. Because subsequent to the publication of the US guidelines, we had the second trial, the DELIVER HF trial, demonstrating benefit with these agents. ESC guidelines in 2023 augmented the recommendation with SGLT2 inhibitors to a Class 1 recommendation in patients with mildly reduced EF. All other agents in ESC guidelines have a Class 2B recommendation, very similar to US guidelines. In patients with preserved EF, because of the evidence from these 2 trials, SGLT2 inhibitors now in the ESC guidelines are again given a Class 1 recommendation. In the ESC guidelines, the only other recommendation for patients with HFpEF is treatment of congestion with diuretics. ESC guidelines remain silent for other additional therapies, partly because most of the studies looking at benefit with ARNI, MRA, and ARB in patients with HFpEF were done in a post hoc manner by analysis, demonstrating potential benefit for patients with preserved EF, but the benefit was actually higher in those with lower EF. So in essence, we currently do state that ARNI, MRA, ARB could be considered as additional therapies in patients with heart failure with preserved EF in the US guidelines. But keep in mind, SGLT2 inhibition right now is a Class 1 recommendation for patients with mildly reduced EF, as well as preserved EF, as well as reduced EF. Therefore, SGLT2 inhibitors now have a Class 1 recommendation in all patients with symptomatic heart failure, regardless of ejection fraction. Examining the comorbidities, we do have specific recommendation for iron deficiency. In the US guidelines, as seen in the right upper column, IV iron replacement has a class 2A recommendation for patients with iron deficiency with or without anemia. Studies have demonstrated improvement in clinical outcomes, including quality of life, functional capacity, and exercise performance. So in our guidelines, we stated IV iron replacement can be helpful to improve symptoms, functional capacity, and quality of life. With subsequent data demonstrating further benefit in these outcomes, ESC guidelines have now elevated IV iron replacement in iron deficiency to a class 1 recommendation for improvement in quality of life, functional capacity, exercise performance. And they also added a class 2A recommendation for reduction in heart failure hospitalizations, because some studies have demonstrated reduction in heart failure hospitalizations with IV iron replacement therapy. We have specific recommendations for treatment of atrial fibrillation, as can be seen. AFib ablation, especially when AFib is the reason for worsening of heart failure. When heart failure can be attributed to atrial fibrillation, in the US guidelines, we do recommend consideration of AFib ablation as a class 2A recommendation. I personally look at the spectrum of treatment of heart failure as initiation of quadruple therapy, very similar to induction chemotherapy in cancer. Additional therapies, very similar to consolidation therapy in cancer, and treatment of comorbidities is further optimization of therapies. So I start making this analogy because the outcomes are very similar to cancer in heart failure patients, that time is of essence. Initiation of quadruple therapy is as important as initiation of induction chemotherapy to change the trajectory of the disease. And if the patient is symptomatic, further optimization is necessary to achieve further improvement in outcomes. One differentiator between US and ESC guidelines are that we, in the US guidelines, look at stages of heart failure and have recommendations for stages. And this is also important because we do recognize that the patients in their trajectory have different episodes. In the US guidelines, we do emphasize initiation of guideline-directed therapies during hospitalization and not to withhold therapy for transient drops in blood pressure or rise in creatinine, which is commonly seen in the setting of hospitalization for heart failure patients, and that the GDMT should be optimized. In ESC guidelines, they now have a level 1 recommendation and 1A recommendation for rapid up titration following hospitalization, with optimization being achieved within 6 weeks as a class 1 recommendation. And this is subsequent to STRONG HF trial, which was a randomized trial demonstrating benefit in all-cause mortality with as well as a safety with rapid up titration of GDMT following hospitalization for heart failure patients. As I mentioned, in the US guidelines, we emphasize treatment according to stages, and the US guidelines are very much harmonized with the universal definition of the stages of heart failure, with the recognition of the emphasis on criteria for pre-heart failure, now including abnormal biomarkers, elevation in natriuretic peptide levels, as well as structural or functional heart disease being diagnostic criteria for pre-heart failure, even among patients without symptoms or signs of heart failure. So individuals at risk for heart failure, such as those individuals with hypertension, diabetes, obesity, and ischemic heart disease, are at risk, stage A. Those individuals with either structural or functional abnormality or abnormal biomarkers, such as elevated cardiac troponin or natriuretic peptides, are stage B. Then is the symptomatic stage C and advanced heart failure stage D patients. We do have a class 2A recommendation to screen patients at risk for heart failure. That this approach, followed by team-based care, including a cardiovascular specialist, results in prevention of heart failure and development of LV dysfunction. So we do have specific recommendations for stage A at risk for heart failure, as well as stage B and stage C and D. And in stage A, for patients with diabetes, because of the evidence of benefit from SGLT2 inhibition, we have a class 1 recommendation for treatment of all patients with diabetes and cardiovascular risk to be treated with SGLT2 inhibition to prevent heart failure. And this slide summarizes the data for benefit with SGLT2 inhibition for primary prevention of development of incident heart failure by a risk reduction of approximately 30% among patients with diabetes and cardiovascular disease. We now have also evidence from another agent, a non-steroidal mineralocorticoid receptor antagonist, finerenone, in patients with diabetes and CKD or microalbuminuria, demonstrating significant benefit in cardiovascular death and heart failure hospitalization among patients with diabetes and CKD, resulting in recommendations in the ESC guidelines for finerenone to be added as a prevention strategy among patients with type 2 diabetes and CKD as a class 1 recommendation. So in the ESC guidelines, we now have patients with diabetes and CKD can be treated with SGLT2 inhibitors or finerenone with class 1 recommendation. Patients with type 2 diabetes and cardiovascular disease or cardiovascular risk with SGLT2 inhibitors. And of course, patients with symptomatic heart failure with reduced, preserved, or mildly reduced EF with SGLT2 inhibitors. So it's important for us to recognize now that treatments of clusters of risk is becoming very important in heart failure prevention as well as treatment of heart failure. So in summary, if we look at the comparison of 2022 US and 2023 ESC guidelines, we have similar EF classes, reduced EF, mild reduced EF, and preserved EF. We have very similar first-line quadruple therapy for HFrEF. The only differentiation is we do have a class 1 recommendation for ARNI as a de novo initiation, whereas in the European guidelines, its class 1 recommendation for ARNI is only as a switch for those who have tolerated ACE inhibitors. And in the US guidelines, we have a stepwise approach. We have treatment algorithm according to the stages of heart failure. Additional therapies for HFrEF, including ivabradine, vericiguat, digoxin, are very similar. Hydralazine nitrates have a class 1 recommendation in the US for African American Black patients, whereas in the ESC guidelines, that's a 2A. For recommendations for mildly reduced and preserved EF, ESC guidelines have elevated SGLT2 inhibition to class 1 recommendation. In the ESC guidelines, other than SGLT2 inhibition and diuretics, other agents are not identified as a recommendation, whereas in the US guidelines, we do recommend or consideration of ARNI, ARB, or MRA as additional therapies as a class 2 recommendation. Hospitalized heart failure patients have similar approach for initiation of GDMT. ESC guidelines have specified optimization of GDMT within 6 weeks after discharge. We do in the US guidelines have a differentiation on the ICD indications. We recommend ICD for all patients with EF less than 35% as a class 1 recommendation, whereas in the ESC guidelines, the class 1 recommendation is only for ischemic cardiomyopathy. For non-ischemic cardiomyopathy, European guidelines have used a class 2A recommendation for ICD. And of course, in both guidelines, there are specific recommendations for treatment of cardiac amyloidosis or other specific etiologies. And IV iron currently is recommended in both guidelines, elevated to a 1A recommendation in the ESC guidelines for improvement in symptoms, quality of life. In the US guidelines, that remains as a Class 2A recommendation as of 2022. And I think overall, we're very much harmonized between the US as well as ESC guidelines, and are hoping to be able to come up with timely optimization and updates in the guidelines to reflect the evidence that we're seeing in the clinical trials. So thank you for your attention.